This ASCO podcast provides observations and commentary on the JOP article Oncology Care in Rural Northern New England. My name is Johannes Christian Nunnink, and I will be presenting a review of oncology care in rural Northern New England. The Northern New England Oncology Society embarked on a study to assess whether there was a disparity in cancer care delivered in rural and urban areas of New Hampshire, Maine, and Vermont. The work undertaken here was to extend the findings initiated by the Maine Cancer Consortium. Clinical indicators of cancer care served as surrogate markers to look for discrepancies in care delivered in rural areas when compared to urban areas in colon and breast cancer patients. The three respective state cancer coalitions, cancer registrars, hospitals, physicians, epidemiologists, statisticians, developed a working group that shared resources, streamlined data access, and developed uniform definitions so that almost 9,000 patient records in 79 separate institutions could be evaluated during 2003 and 2004. The ability to access data in such a large geographical area enabled a statistically valid comparison that would not be possible if it were confined to one state. The goal was to take a snapshot of cancer care delivered in northern New England. Evaluation of differences in care offered in rural areas could be assessed to identify needs and barriers that could be addressed. The results showed several interesting findings. Breast cancer patients in urban communities were diagnosed more often with non-invasive breast cancer than patients living in rural areas. This finding may have several explanations, including access and availability to screening or ability to obtain or interpret biopsies in rural areas. Further studies will need to be done to clarify this important finding. Moreover, breast cancer patients in urban areas also had more sentinel lymph node procedures than their urban counterparts. The sentinel lymph node procedure was just diffusing into the community from major teaching institutions in northern New England and replacing the previous standard of regional lymph node dissections during this time. The ability to capture community acceptance and expertise of a new therapy, i.e. sentinel lymph node dissection, over time is also an important finding. It would be interesting to see how rapidly this and other new technologies are accepted and utilized in the rural community setting. Breast cancer patients undergoing sentinel lymph node dissection also received more post-lumpectomy radiation therapy than patients who did not receive sentinel lymph node dissection. Even though no geographical variation between rural and urban areas was discerned, it would suggest that patients with access to new technology also had easier access to radiation therapy. Defining variations in access to care, therefore, may be better measured if we look at the difficulty patients may have in getting to the institutions where the care is delivered, i.e. looking at driving times. The same issue was found to be true in colon cancer patients. Postoperative chemotherapy is usually recommended in patients with stage 3 colon cancer. A significantly higher proportion of patients received adjuvant chemotherapy in urban rather than rural areas. The significance of these findings will require further testing and evaluation. This study had several limitations. For legal and logistical reasons, this study was based on aggregate data pulled from 3 states. The lack of individual data precludes the use of multivariate analysis to examine and adjust for confounding variables and limits our ability to interpret the results. Continuing to do this work prospectively will enable us to collect data in a scientifically and instructive way and hopefully would give us an ongoing tool to clarify some of the issues noted here and find strengths and weaknesses in the fragile care network now in place in rural northern New England. We were able to plot a map which illustrates the accessible points into the system. Are these sufficient? Do we need more resources? And if so, where? The answer to these questions will be critical if we hope to cure more patients with cancer. The development of new technology and therapies will not save lives if patients do not have access to these new treatments. The future will only improve if important tools to measure how we do over time are developed. And that is and continues to be the major goal of this study. Before we can break down barriers to care, we have to see if and where they exist first. This concludes this ASCO podcast. Thank you for listening.